Jain for her talk.
So, presbyopia correcting IOLs and toricity correcting IOLs have revolutionized refractive cataract surgery today, because evolution in optical material and designs allow today for a much better functionality whilst minimizing the side effects. So along with the newer lenses that are available, which cost a lot, there also comes with that the flip side is the increasing patient demands. And therefore, the need to satisfy these patients makes it very important for us to understand not only when these lenses are indicated, but even more importantly, when you would avoid using these lenses, or at least give it more than a single thought. How do I go down? So I'm going to start with when would you consider not putting in a multifocal IOL, right? So I think the first and the most important factor here is evaluating. I mean, we do know that when we do use these premium IOLs, it also requires more chair time to understand what is the patient's visual needs. So if you've got a patient who is extremely demanding, hypercritical, of a type A personality, a complete perfectionist, somebody who's saying, no, this is what I want spectrum independence, there's no way I'm going to accept any kind of glasses or anything like that. Someone who's unwilling to accept optical aberrations, photic phenomena, unwilling to give it that little time for the brain to neuroadapt to the photic phenomena should he get it. Someone who's not willing to accept anything other than 6/6 and 6, or the possibility that at some point there may be a need for a surgical enhancement. I would avoid a multifocal IOL in these patients. I think also with respect to their profession, those who are heavily dependent on night vision, like drivers, truck drivers, pilots, or people who drive home at night and who might be bothered by the glare, I would really think again and talk to them about it. If you put in a multifocal in one eye and the patient is happy, you're going to actually be wondering about what to do about that eye rather than certainly you're not going to be considering putting the same lens in the other eye. And I think the commonest, what I find in my practice is many people of the older age group, they're very happy to wear glasses. And they actually come around and tell you, no, I'm very happy to wear glasses. I would actually not want to be without glasses after surgery. So these patients, you go with a bang on, as close to emetropia with a good biometry, and give him a pair of progressive glasses, he would be just as happy. So there's no point in actually just pushing for a multifocal IOL there. I think I would consider not putting them there. With respect to refractive errors, I think low myopes are usually happy with uncorrected near vision any which way, but I'd like to talk to you more so about high myopes. I mean, there is a changing trend now. There was a tendency to avoid putting multifocal IOLs in high myopic patients, but I have discussed this extensively with my retina colleagues. If they have been evaluated preoperatively and you do find any treatable lesions, you can go ahead and treat them. In the cataract age group, it's unlikely that after you've treated those lesions, I'm not quite sure, but I don't think that they're likely to develop new lesions after the surgery despite having opened up the anterior chamber. So I think today I do not think that multifocal IOLs need to be contraindicated in them, provided you explain to them that you may require a regular retina follow-up. I've also checked with my retina colleagues. They do say that it is possible to even treat the retinal lesions should they occur even after putting in a multifocal IOL. So that again is a personal choice. Now, if patient has a regular corneal astigmatism, whenever we are planning a multifocal IOL in either eye, it's very important to look at the corneal toricity in both eyes. So suppose the first eye that you were planning to operate has got no cylinder, but in the other eye he's got a significant cylinder that requires treatment. Then I would think twice and I would discuss it with the patient, because we do know that the cost, because we need to correct the toricity. Certainly a regular corneal astigmatism has to be addressed when you're putting in a multifocal IOL. The reason being that if you've got a cylinder of 1 or 1.5 diopter or more, you are going to have a degradation in the visual quality, you are going to have a compromised distance and near vision, and a significant halo effect can be achieved, will occur or could occur just with a residual cylinder. So if the patient has a cylinder in either eye, you have to discuss the cost of implanting a toric multifocal lens. And if should that be a problem, then I suggest go ahead with the monofocal in both eyes and just give him presbyopic glasses. Now, when you talk about irregular corneal astigmatism, this again is a whole gamut of conditions. What is causing it? I mean, Sir just discussed about a corneal dystrophy. A map dot corneal dystrophy, which looks like a subtle problem, can cause significant optical aberrations, and this patient will not be happy. Suppose you had corneal scars or you had a pterygia. Let's discuss that. If you have a central corneal scar, definitely is going to be a lot of light scatter and suboptimal vision, and you would avoid it. But what if you had a tiny scar in the periphery, which is not in the visual axis, resulting in a stable astigmatism? Then I think a toric multifocal can be used. So also for pterygia. Now, in pterygia, what you need to know is, I think it's best to do pterygium as a sequential procedure. You first do the pterygium surgery, you wait for a period of 1 month to up to 3 months, depending on how large the pterygium was, only then consider a multifocal IOL. When you've done a series of topographies, and preferably not Placido-based, but Schemflug-based, because a Placido-based topography looks at the tear film, and that is often distorted following cataract surgery. You will not put in a multifocal IOL until you've got a stable ocular surface. So you have to rule out irregular corneal astigmatism, because irregular corneal astigmatism is going to limit the predictability of your eventual outcome, is going to cause issues of wound healing, dry eye, and optical photic phenomena. Now, dysfunctional tear syndrome is a big gamut of, again, clinical features that happen with themselves, but you need to know that you put in a multifocal and you've got a patient who complains of glare and halos. Halos itself can be caused because of a dysfunctional tear syndrome, and therefore, should it be there, it should be treated to the maximum possible, manage the lids well, manage the ocular surface well, stabilize your ocular surface, then and only then consider multifocal IOL. If you are unable to do that, it's perhaps best avoided in very, very severe dry eyes. Patients with corneal aberrations, I think, again, is best avoided, because coma and things like that itself can result in enough of a halo effect. Now, if you've got a patient with a Fuchs corneal dystrophy with few cuttae, and it doesn't look like the kind that's going to be subject to any kind of a DSEC, it's not too bad. Just plain cuttae and some amount of corneal thickness itself can result in glare, halos, and in conditions of reduced illumination. A very large pupil, a large angle kappa, or you're using a small pupil with iris hooks during the surgery, it's going to cause a glare dysfunction. And don't forget that patients with coloboma of the iris and an ectopic pupil are also likely to have a subluxated lens, and that again can cause its own issues. When we talk about zonular dialysis, pseudoexfoliation or a progressive zonulopathy can result in a post-operative decentration of an IOL, even if it looks centered to start with. A decentered multifocal IOL is going to cause suboptimal vision, increase in optical aberrations, and certainly a reduced contrast. Retinal issues depends upon, if you've got a maculopathy, is it stable, is it progressive, what is the available treatment, and it can cause impaired vision and a reduced contrast as well. I'll just take another minute. Optic nerve issues, it causes decreased color vision, contrast, as well as restricted field, and is probably best avoided. So also in patients with alternating squint, as well as can result in absence of binocular summation and therefore are avoided. If you have an intraoperative PCR, post-refractive surgery, unless you're able to bang on, do the workup properly, it should be avoided. And finally, just a tip upon, when would you not put in a toric IOL? If you've got a patient who says, I'm not fussed, I'll wear the cylinder in my glasses, or you guarantee me that I'm going to have no residual cylinder of even 0.25, I would avoid a toric IOL in these patients. If you've got, what do you consider a significant toricity? Now we know we have the posterior corneal astigmatism. So if you are able to take care of, if you have an astigmatism less than 0.1, 0.25 or 1.5 with the rule, or less than or equal to 0.75 against the rule, I wouldn't put in a toric IOL anymore. Suppose you can manage just a 0.5 diopter of toricity with an on-axis incision or an opposing clear corneal incision. This is another modality to treat it intraoperatively. You can avoid it. In case of irregular astigmatism, If you have a stable irregular astigmatism and you're able to determine the magnitude and the cylinder, today I think I would go ahead and put in a toric IOL because the patients would be happier. If you've got a comorbidity, patient has an astigmatism, but you have a grossly subluxated lens, it's not going to work. So because this subluxated lens is going to have its own issues. If you've got a significant corneal astigmatism, but the patient has a pre-existing open posterior capsule, you don't know where you're going to put in the lens, you'd avoid it there. And if you have a progressive keratectasia, it's also best avoided. Make sure that the astigmatism is purely corneal. If it is a lenticular astigmatism, then again, doing a toric IOL is not going to work. And my last slide, aspheric IOLs would be avoided. It's not going to work if you've got a residual spherical or a cylindrical error, if you've got an eccentric pupil, if you've got a decentered IOL more than 2 millimeters, or if you've got a senile miosis. Thank you very much.